The purpose of my policy analysis project is to identify a policy that will help to increase both the access and availability of pediatric mental health services in the Central Appalachian region. Studies conducted by the Appalachian Regional Commission show that the mental health provider population in rural Central Appalachia is 35% lower than the national average. Children deserve specialized care. The CDC states that 15% of young children ages 2 through 8 in the United States have a mental, behavioral, or developmental disorder diagnosis, and that number goes up to 18.6 in small rural areas. Several factors can contribute to the more poor mental health of children, and two of these that are especially big in Central Appalachia are the opioid crisis and the increased use of technology and social media. Problem with access. Central Appalachia faces a number of predisposing and enabling health risk characteristics that make its people particularly vulnerable to mental illness and difficulties accessing care. Those predisposing characteristics include negative beliefs about mental health and small town culture, a high proportion of individuals of low socioeconomic status, a lack of education, and a high unemployment rate. Those enabling characteristics include a lack of resources due to low income, poor insurance coverage, absence of public transportation, and geographic isolation. Many Central Appalachians find themselves at points of dimensional overlap, wherein they are affected by a multitude of the previous factors all at once. The problem with availability. Primary care physicians and pediatricians are often the only or one of the few sources of mental health care available in the region. Even in those counties who do have mental health providers, there simply aren't enough of them. Frontier Medical has several counselors. However, I spoke with Andrea Jones, a physician assistant at the clinic, who told me that they are booked up for several weeks in advance and very difficult to get in with. Mountain Comprehensive Care is another resource available. They offer counselors both in schools and in the clinic. However, Don Williams, a former employee at Mountain Comprehensive Care, told me that it's extremely difficult to get counselors who want to work with children in the clinic or who will agree to do so. And then Mrs. Jones again told me that the counselors in the schools, this isn't great. There's an issue with continuity of care here because they don't get to see the same kids very often because they have so many schools to travel to. There have been no real policy efforts to try to increase the amount of pediatric mental health providers in the region. While we do have federally qualified health centers and we do have rural health centers, they still can't keep up with the demand. Therefore, 4 policy options will be presented. And 5 criteria will be used for evaluation. These are accessibility, which will refer to the ability of rural Central Appalachian children to receive mental health care. Availability, which will refer to the number of providers in the region. Comprehensiveness, which will refer to how many aspects of the problem that the policy option addresses. Quality will be a measure of the treatment received, or in other words, how thorough the treatment is. And cost will be measured as how much money, resources, and time it will take to implement the policy. The first policy option is loan repayment programs. Mental health care providers could have 3/4 of their total student debt repaid if they agree to practice pediatric mental health care full-time in an assigned Central Appalachian County for 3 years. A similar program currently exists through the Health Resources and Services Administration, and it can be used as a model. However, it focuses on primary care and substance abuse treatment rather than on pediatric mental health care. Providers have the option to work part or full-time for 3 years, but they can only receive $100,000 of their total student debt repaid. And on average, this is only half or less of the typical total student debt. This would make it easier for low-income families to have care closer to home if you brought providers to the region. And I think increasing award amounts from the program that currently exists would make more people want to apply to the program, but there would still be many who wouldn't see moving to such a rural region as worth it when they could be paid more in an urban area. Quality wouldn't be an issue here because you could select the best applicants to come to the region, and it would provide children with quality in-person services and providers who can prescribe medications so they don't have to be referred back to their primary care provider, or to another clinic even further away. This program would be extremely costly because education is costly and it would take a lot to repay three-fourths of every applicant's debt. There's also an opportunity cost associated where you're making a big investment on someone who might just leave the region after their contract is up in 3 years. So therefore, with comprehensiveness, it would solve maybe half of the issue. The only factor it really addresses is availability, but if it brought even a small provider or small number of providers to the region, it would definitely help. The second policy option is telehealth. It's something that current providers in the area could offer, and partnerships could also be formed with providers outside of the region so that the few providers here don't get overwhelmed, and more children have access to the service. Kentucky state telehealth laws would need to be changed here to allow for telehealth services to be received across state lines and again, just give kids more options for care. Children would have great access to care from their homes, and where they don't have, in kids who don't have a device at home, they could always use devices at their schools. They could have access to providers from all across the state, as well as other states right at their fingertips. The one potential drawback to this policy is quality, as it could be harder to establish a close patient provider relationship over a phone, and physical signs of mental illness might not be as obvious. Um, it wouldn't be costly to implement. They would be cheap because most clinics already have a device that they can conduct telehealth on. They are reimbursed the same as in person visits, and it would ultimately be cheaper on the patient. So this solves both the problem with access and availability, as well as many of the underlying factors that are associated with these problems. The third policy option are day treatment centers, and this would be modeled after one that is currently in Ashland, Kentucky. However, that program is court ordered for juvenile offenders. This program or these programs would be for any child with a serious mental illness and not court ordered. Um, Mental health professionals and school teachers could both work at the center so that they can receive care, and they can also receive their schooling in a controlled environment. The center would be completely state funded, and children would have free transportation from their schools. Services would come at no cost to the child or their family. So it would solve a lot of issues of accessibility, like transportation wouldn't be a worry, having a low income or a low socioeconomic status wouldn't be a worry, since it would be state funded. But only a small number of children could be accepted at a time, so it could leave a lot of kids out, and it could leave out kids whose mental health issues aren't as serious. It could potentially increase the number of providers in the region, as being a state employee might be something that's appealing to people. Quality of care would really only be an issue if too many kids were placed in the program at one time, overwhelming counselors. It would be very costly, as the state would be completely responsible for everything from the building to upkeep to salaries. So it's not really the most comprehensive, since there would be children who would be left out, and it's really only for a certain type of child. The fourth policy option is the integration of primary care and mental health care, which would take providers who are already practicing in the area and give them extra training on mental health. State laws could be implemented in Appalachian states that require any provider practicing in counties who have poverty rates that are higher than the average in their state to receive extra training in mental health, just in the form of continuing education, virtual classes. It would increase access among children who are low income and have poor insurance coverage, can't really afford to travel and see a specialist. It could potentially also be a way around certain stigmas, because people could just get the care in their primary care physician's office rather than going to a psychiatrist. There wouldn't be an increase in any new mental health providers, but it would make the providers already here more equipped to deal with the cases. Quality could be a concern, as these providers still wouldn't be specialized, and they could potentially become overwhelmed, as they would be taking on extra duties that they didn't originally intend. The cost could vary depending on the training program selected. The American Academy of Pediatrics offers free courses, so this could be a great option. And the provider would receive this at no cost, as it would be state funded. but they could be fined if they don't complete the treatment. So I really feel like this is only a band-aid solution because providers still wouldn't be specialized and children could still lack resources to be able to travel to the clinics. Therefore, my recommendation is the telehealth policy for the following reasons. It provides the most access for children in Central Appalachia. It's the most cost effective. There are some quality concerns, but they definitely aren't steep enough to outweigh the major benefits. And it's therefore the most comprehensive option. In order to implement this, Kentucky State Legislature would be called upon to change the existing laws to allow for services across state lines. Partnerships would need to be formed with providers out of the area who agree to take on an extra patient load. And there would be a need to coordinate with schools in order to schedule times for those kids that don't have access to a device at home to be able to use school devices. Then it would need to be advertised once it's implemented and all said and done. And this could be done through referrals through the primary care physician, a website that could list all available services and links to sign up, as well as just ads and social media sites. So again, to wrap up, I think telehealth is definitely the best option. It's something that is becoming more common anyway due to COVID. So it would be an easy implementation and really think that it would be able to reach a lot of children in need. And these are my references. Thank you so much.